during my talk, I would like to give you my personal view on the current treatment concepts of adrenocortical carcinoma. And at the end, I will provide you at least some ideas of future concepts. Since probably not everybody from you is dealing with patients with adrenocortical carcinoma on a daily basis, I thought I'd start with two background slides. This is a rare disease, and it can appear at any age. Usually, females are a little bit more affected than men. At the time of primary diagnosis, about almost two-thirds of the patients suffer from endocrine hormone excess. In 1/3, you have local symptoms, and more patients are actually detected by imaging. And if we look for the hormone symptoms, it's in most cases a Cushing syndrome or an androgen excess. And you might imagine that this woman with an androgen-producing ACC is not only suffering from the tumor burden, she's suffering from the androgen excess. So this is a really, at least in part, terrible disease. How's the outcome? What is the overall survival? And the median overall survival of this disease is about 3.5 years. So, and if you use the revised TNM classification, which we established by the NSAT network, you see that as it should be for a staging system, that the overall survival is stage dependent. And for example, patients with a stage 4 disease, metastatic disease, they have a median survival of about 1 year. So they are dying very soon. However, one of the first messages I bring to you is that despite this fact, the outcome, at least in some patients, might be better than we anticipated. And this is an analysis which we performed some years ago, where we focused now only on stage 2 patients. So this is localized disease, and this is the stage, at least in our hands, which is where most of the patients are dealing in. And the point is, these are series, 5 different series from different countries, and you see the median survival in stage 2 is about 75, 80 months. And when we look this in our German registry, you see almost identical results. However, what we did then is we divided the patients. We had a group of patients which were referred to us right at the beginning of the diagnosis, so at least within 3 months of the primary diagnosis. And we compared these groups with patients who were referred to us later. And you see a dramatic difference on overall survival. You have to acknowledge this is only a small subgroup of 30 patients. However, this is already by now statistically significant. And the reason is, if you look, what are these patients? These patients are patients who referred, at least many of them were referred to us after recurrence. So there is clearly a bias, and therefore we believe that in most years, including our own, there is a bias, a selection bias, because patients who are cured by surgery never show up in any reference center. And therefore, we suggest or believe that at least in localized disease, the prognosis is much better than anticipated. However, now turn to treatment. There are 3 cornerstones of treatment: surgery, mitotain, and cytotoxic drug. And none of them is really pleasant. Let's start with surgery. Surgery is without doubt treatment of choice in localized disease. But there are 3 main challenges or problems. First is the capsule is thin and fragile. This we cannot change. But the second point we might change, and we should change. Right now, most of the adrenalectomies are performed in low-volume hospitals. Data from the US, for example, demonstrate that 2/3 of so-called adrenal surgeons perform less than 6 adrenalectomies per year. This is including benign disease, or most of them are benign disease. We analyzed now our data from Germany, and in the period of 10 years, we had 472 primary adrenalectomies for ACC now. And they were performed in 234 different departments. And only 6 centers performed more than 10 surgeries within 10 years. Clearly dealing that these patients were almost all treated in low-volume hospital. And this might have an impact on their survival. And this we can change and should change. And another problem is that there are no real standards. There are many open questions in the surgical field. Just 2 examples. It's unclear if you should go for open surgery or if minimally invasive surgery is acceptable. And there are almost no data on lymph node dissection. And I will give you to each of these 2 last points just 1 slide as an example. What we did, we analyzed 150 patients with ACC, localized disease, and compared 35 patients with laparoscopic surgery with 170 patients with open surgery. And to be honest, at the time we performed this study, we were completely convinced that laparoscopic surgery is a mistake. However, then we had to learn that there is no significant difference. And we did a multivariate analysis and nothing changed. And if you look for overall survival, again, it's the same. So there is no significant difference. We have to acknowledge this is retrospective data, and there are, in the meantime, 5 other studies, and the data are not completely conclusive. But I thought for time reason I have to stick to 1 study, and this is by at least the largest study on this topic. However, I do not promote laparoscopic surgery, but I argue in experienced hand it might be at least acceptable. Turn to the role of lymph nodelectomy, and there are actually by now only 1 study on this topic. This is again a retrospective analysis which performed with our local surgeons in Würzburg. And as you can see here, for recurrence-free survival and for overall survival, so there's a significant improvement if lymph nodelectomy was performed. And therefore, my personal recommendation, at least right now, is treatment of choice for localized ACC is certainly the complete tumor removal. This is obvious. However, you should include lymph nodelectomy. And another important point is really go to or search for an expert surgeon. The number of adrenolectomies per year is completely arbitrary, but we believe that it should be at least 20. And the surgical approach, however, is probably less important. It's probably more the matter how experienced your surgeon are. However, after surgery, the challenge is not over. And the next problem is pathology. We analyzed between 2006 and 2009, and this was done by Sarah Johansson. We sent all our tumor samples from patients which come to our center to our reference pathologist, Wolfgang Säger. And to our surprise, and we were really shocked, 21 of these patients, 13%, the diagnosis had to be revised. So this was no ACC. It was any of these other diagnoses. And you can imagine that the treatment would be completely wrong. And therefore, this is a major problem of the disease. And there's obvious need for a better marker, probably immunohistochemical marker. And to improve this, we tried to establish such a new marker. This is a study mainly done by Silvius Fiera from our group. And we established steroidogenic factor 1, which is a well-known gene in the adrenal field, and could demonstrate that staining, that all the normal and benign adrenocortical tissue samples were positive, and almost all ACC samples. However, none of the non-steroidogenic tumors were positive. Here, for example, you see a nice example of a renal cell cancer, which is clearly negative, but the adjacent adrenal is clearly positive. So within 1 slide, you have a positive and a negative control. And if you do the analysis, sensitivity and specificity are very high, and we believe that SF1 is now one of the markers that should be on every pathology report for adrenocortical tumors. Although I mentioned that the prognosis might be better than anticipated, recurrence is still a frequent event. And the question is, how can we prevent this? And I still believe that the best study on this topic is this study already published in 2007 by Massimo Terzolo. where we in this study compared patients treated with mitotane with two different control groups. And as you can see here, the mitotane patient did significantly and much better than the control patients. And this was also true for overall survival. However, mitotane is toxic. It's a derivative of DDT, an insecticide, and you can imagine that this is definitely a toxic drug. And on the long run, more than 90% of all patients experience at least any of these side effects here. And therefore, and not only therefore, the adjuvant mitotane is still disputed. It's still retrospective data. And therefore, there's this big debate if this is really the right drug in this situation. However, there are more evidence, again, collected by Massimo Terzolo, now as a European study from the ENSAT network, where 122 patients were analyzed where we had mitotane blood level available. And what you can see here, that a patient who achieved the blood level above 14 and could maintain this blood level, these patients did significantly better in recurrence-free survival than patients who never achieved this blood level or could not maintain this level of 14. Therefore, this is another piece of evidence that mitotane really is doing a job, and this is something like a concentration effective correlation. So we are quite convinced that this is an important drug in this concept. However, the question is, are there any risk factors which could guide us in the decision for or against any adjuvant treatment which is so toxic? And for this purpose, we analyzed all kinds of different factors, actually basically many histological factors, but also immunochemical and also clinical data. And this is a study which we performed together with Felix Bäuchlein. And interestingly, out of these 26 factors, Ki67, a proliferation marker which you might know from neuroendocrine tumors, is by far the best single predictive factor. And you could see patients with a Ki67 below 10 do much, much better than the other groups. And this was confirmed in an independent control group by the ENSAT network and was the same for overall survival. Therefore, we believe that Ki67 should be another factor which has to be mentioned in the pathology report of every adrenocortical tumor, because this is an important factor for the prognosis for the patient and then for treatment. However, most of these studies are still retrospective and we need prospective trials. And one of these trials is the Adjuvo trial, which is currently running. And in this trial, led by, again, Massimo, we focus on low and intermediate risk patients, because we believe the normal risk patient, it's almost unethical not to treat them. But in this small subgroup, we really aim at a randomization at mitotane versus observation only, but it is only a small subgroup, therefore it's really a challenging trial. And if you have a patient who qualifies for this, please contact any of these Adjuvo centers around Europe and include this patient. In case you have now recurrent disease, you have one of the major questions is which patient might benefit from a second surgery? And to answer this question, we performed another retrospective analysis with 150 patients, and again, many factors which were included in the analysis. And two factors actually at the end stayed as the most significant. This is disease-free interval and the resection status. If you see, for example, here, patients with a time to first recurrence of more than 12 months do much better for overall and recurrence-free survival than patients with a shorter disease-free interval. And also the resection status is of major importance. You see that seroresected patients do much better. And for instance, there is no difference between arterial resection, debulking surgery, or no surgery with regard to progression-free survival in this subgroup. Therefore, we conclude right now, based on this data and based on all other retrospective data from other groups, that patients we recommend for surgery for all patients with a time to recurrence with more than 12 months, and if we can achieve complete, or our surgeons can achieve probably a complete resection, but we recommend against surgery if the time to recurrence is shorter than 6 months, or in case complete resection is unlikely. Now we turn to advanced disease. So this is the most devastating part of the disease. And in this context, you have to discuss about the Fassnacht trial. The Fassnacht trial is the first randomized trial in ACC ever, and by now the only published phase 3 trial. This is a trial of 40 different centers around the world, and I had the honor to run this trial together with Fritz Skogside and Massimo again. Fritz is from Sweden, Massimo from Italy, and we run this trial and compared the 2 most promising treatment regimens at this time, and they are still one of the most promising, and this is etoposide, doxorubicin, and cisplatin plus mitotane versus streptozotocin plus mitotane. And then there was an evaluation every 8 weeks, and in the case of progressive disease, the patient had been offered the alternative regimen. And here you see the main outcome, the primary endpoint, overall survival. And if you're not very used to this kind of curve, a Kaplan-Meier curve in oncological trial, you would argue they look quite similar, and there's probably not a big difference. And it's definitely not significant. However, I would demonstrate that there might be a difference. Here, for example, you see progression-free survival. And you see that there is a difference. And if you, for example, look at 12 months progression-free survival, you see in the EDP groups 26% versus only 8%. And this is from a patient perspective, definitely a clinical meaningful endpoint. So there is some difference. And if you then look the second line therapy, and again you see the EDPM regimen is doing much better. And if you compare first line with second line therapy, it is at least tempting to believe that this success in second line is responsible for that we did not reach any significant difference in overall survival. And finally, if you note that adverse effects and quality of life were quite similar in both groups, you might follow my conclusions that EDP is definitely better. However, we have learned several things from this Fassnacht trial. First, a large randomized trial in a very rare disease is feasible, at least if really many enthusiastic investigators around the world joined forces. And I would like to thank everybody in the audience who supported this trial and who participated as investigators. Second, we have learned that EDP is now standard of first-line chemotherapy in these patients with advanced ACC. However, there's more than we learned. We need definitely new treatment concepts because medium overall survival of 15 months, of less than 15 months, is disappointing and certainly cannot be the end. So we need new concepts. And since EDPM is similarly effective in second-line therapy, we believe that it's justified right now to use, at least in selected patients, either mitotane monotherapy in the mitotane-naive patients as first line, or new therapeutic regimens right in the beginning, ideally within a clinical trial as first-line therapy. And in the next few slides, you will see why I believe it's important that we use these new experimental drugs in first-line therapy. And if we discuss about new drugs, we certainly have to discuss so-called targeted therapies. They are used now for many, many diseases in the oncology field. However, the results of phase 2 trials in ACC with these new drugs are more or less disappointing. And therefore, I would like to share only one trial with you. This is the CERAC trial, a trial which we run in Germany with a multi-tyrosine kinase inhibitor, Sunitinib. And we investigated 38 patients, and we defined response similar to parallel trials in other European countries with a stable disease of more than 12 weeks. This is not a very tough definition. However, these were patients in second, third, and sometimes fourth line therapy, and we saw that 12 weeks is already an achievement in this type of disease. And you see in this trial, we had a response rate, so-called response rate of 14%. So again, not very exciting. However, this study was important for another aspect. And this is the interaction of mitotane and sunitinib. Certainly, we allowed mitotane to be continued because we believe it might be synergistic. However, we have to learn that only 1 out of these 20 patients who really had concomitant mitotane experienced a stable disease, whereas 4 out of 15 who stopped mitotane had a stable disease. And then in the next step, we analyzed the mitotane blood level and the Sunitinib blood level. And we had to learn that the higher the mitotane level, the lower the Sunitinib level, and vice versa. Therefore, we are quite convinced that mitotane diminished the Sunitinib blood level, and therefore Sunitinib might be a more promising drug in mitotane-naive patients. And this is probably true for many other new drugs, because in the meantime we have had to learn that mitotane is a strong, if not the strongest, CYP3A4 inducer, and this enzyme is the enzyme where many different drugs are metabolized. So all kinds of cancer drugs, but many other drugs as well. So this has direct implication for clinical care of patients on mitotane. And this is now supported by several other studies, also from other groups. So in the last part of my talk, I would discuss a little bit future perspective and goals. And I will will cover 3 topics. First is to improve current treatment, and I will discuss with you mitotane. Second, new treatment concepts, and I will provide you one which is iodometomidate. And in the last part, to discuss shortly about an improved understanding which is necessary to really make further progress. Let's start with mitotane. You have heard this is the cornerstone of medical treatment in adjuvant, but also in advanced ACC. And it's almost unbelievable that it's now in clinical use for more than 50 years, but the molecular mechanisms are still obscure. And to change this, Matthias Kreuz and Silvius Piera in our lab decided we start with in vitro studies. And what we performed, first we looked just normal apoptosis assays, and we confirmed what others have already found, that if you treat these cells with mitotane, you will get an increase of apoptosis. But this was known already. So we decided we go for micro-expression area analysis, and this was performed. And then we performed all kinds of pathway analysis. And at the end, 3 major pathways turned out to be important. One is apoptosis. The other one is that we found a disturbed sterol metabolism, which was for cholesterol, cortisol-producing cells, not completely unexpected. But we found also endoplasmatic reticulum stress. And this is something at least 3 years ago we did not even heard of. But this is definitely major importance for these cells introduced by mitotane, but also for many other diseases right now. And so we looked further, first for the sterol metabolism, and could demonstrate that these are the ACC cell lines, and these are 2 other cell lines. If we treat them with mitotane, these adrenal cells accumulate lipids in a very dramatic fashion. And if you look a little bit more in detail with LCMS, we could demonstrate that the free cholesterol is increasing significantly, and free cholesterol is toxic for the cell. And therefore, this is a very interesting finding. You will hear much more details from Silvio, who has a talk on this on Sunday afternoon. And I just would like to summarize our proposal for the mitotain action. So we believe mitotane is entering the cells, and then by a variety of different mechanisms, it induces toxic lipids. And in parallel, it's a disturbance of the mitochondria, and these both aspects together induce endoplasmatic reticulum stress. And this is then responsible for a decrease in steroidogenesis and apoptosis. Next part is new treatment concepts. And here I have to introduce metomidate. Metomidate is a drug which is used usually in veterans medicine, which is an inhibitor of CYP11B, which is the last step of aldosterone and cortisol synthesis. And this enzyme is exclusively expressed in the adrenal cortex and in tumors derived from these type of cells. And metomidate can be used for adrenal imaging. This was demonstrated by Steffi Hahner and Andreas Schierbel already some years ago, and several other groups at the same time have found this as well and used this as imaging tracer. We went then one step further because we had a method which used an iodomethimidate, and we exchanged this 123 iodine with 131. So the radioactive, which is used for radiotherapy, radioiodine therapy in thyroid cancer. And here, for example, you see a patient, 37-year-old, with an aldosterone-producing carcinoma. And you see, these are the PET imaging before therapy, and this is after therapy. And you see the PET tracer uptake is disappeared. And we also see in the CT that the lesions are getting smaller. So this was a single case. However, if you look through all our patients, we have treated so far 11 patients on a compassionate use program, and you see that in the majority of patients we can achieve disease control. So not all of them have such a shrinkage, but you have at least disease control, and this treatment is almost not toxic, at least in comparison to all other drugs which we have seen. Unfortunately, for bureaucratic reasons, we had to stop the program, but actually we are just in the process to relaunch it and probably will treat our first patient in May this year again. So hopefully this will give some more hope in the future. And the very last part of my talk, I will discuss with you better treatment options require definitely a better understanding of the pathology of the disease. And to this end, Christina Ronke in our lab performed a high-resolution SNP array analysis from adenomas and from carcinomas. And not surprisingly, we found many more alterations in the carcinoma. However, this high-resolution method could demonstrate where are these hits and which genes are involved. And I do not have time to go in detail because we went 2 steps further, one in adenomas, and you have heard this study already by Ashley. And this is a study where I run together with Felix Beuchlein and Bruno Aloglio, where we performed this exome sequencing in 10 adenomas, and we were really happy to found the first somatic mutation in this catalytic subunit. And as you've heard already, we did then a lot of detailed functional analysis, which were mainly performed by Davide Calipiero, and could demonstrate that this is really the driver mutation. And we analyzed additional 180 adrenal tumors and could demonstrate this mutation is only in patients with overt Cushing. And in this subgroup, this is more than 1/3 of the patients who have this specific mutation. And the latest news is a study which is just published 2 weeks ago, or almost 2 weeks ago, and where we performed similar stuff in ACC now. And this is a study run by Guillaume Assier and Jérôme Bertherat from Cochin Hospital. And they performed an exome sequencing again, but additional complementary omics study, meaning SNP arrays, methylome, expression arrays, and so on. And we had an independent control cohort again from this NSAT network. And what they found was that we had new and potential driver mutations. And some of these candidates, like TERT, are known, at least for other types of cancer, but some of them were completely unknown. So we seem to be that we are on the right way. And this integrated genomic analysis, were then able to demonstrate different subgroups of patients with different prognosis. And therefore, I believe that this is an important finding and will lead to an improvement of our understanding of the disease. So I'd like to summarize. Patients with suspected ACC have to be treated in specialized centers, and the selection of surgeon is of key importance. Most patients, even after complete surgery, might benefit from adjuvant mitotane. If you have low-risk patients, a small subgroup, you should enroll them in the Adjuvo trial. In advanced ACC, mitotane or the combination of mitotane and EDP is now standard of care. However, we need better treatment, and therefore most patients should be treated within clinical trials, because only within these clinical trials we can understand or can improve our patient care. However, we definitely need a better understanding of the molecular pathogenesis to further improve our situation for our patient, but I believe we are on the way. With continuous collaborative efforts by many, many groups throughout the world, but I believe many of them are in Europe, we should be able to improve further patient care in ACC in the upcoming years. And this is something like a road which hopefully lead to further success, but I think it was already successful, and from my perspective it started in 2000. This was the time in Germany the Ganymed network was founded. Actually, honestly, the French with the Comet network were already some years earlier. But the critical year probably was the year 2003. In this year, ENSAT, the European Network for the Study of Adrenal Tumor, was founded. In parallel, we established the German ACC registry, and the first international conference on adrenocortical carcinoma was established. And at this meeting, we initiated the FIRMAC trial, which then finally in 2004 started. And this was an infrastructure with many centers in place that many other trials could be performed within a relatively short period of time. Like certainly mentioned only a few of them. But these were important, and some of these trials are not yet published or still running. And in parallel, many of these investigators performed translational research, and I only highlighted the OMIC study by the Cochin group, which was published just recently. And therefore, I believe we are on the right way, and it's important that we continue with this collaborative effort. With this in mind, I have to say thank you. And this is of the most important person is without doubt Bruno Alolio. Unfortunately, if you have heard, he cannot be here today, but he was my mentor now for almost 20 years and became a really good friend. And he was and he is still my role model for being an empathetic physician, but also an enthusiastic researcher. He is a real clinician scientist in the best way. And many of the ideas from him were actually demonstrated by me today, and because he gave input to many of these studies which we have performed. However, there are many more people. From Würzburg, there are many, many people. Steffi Hahner, Matthias Kreuz, Silvio Spiera, Michaela Haaf might be only the most important, but many of them were contributor to all these different studies. And certainly there are not only Würzburg people. As Hans already mentioned, I was in Munich for almost 2 years. I'm now back in Würzburg since several weeks, but I spent 2 years in Munich, and this was many people in Munich who contributed as well to this work, and I have to mention Felix Bäuchlein, by the way, the winner from last year EGE prize, and Martin Reinke, and they were actually also important in the beginning of my career. Martin Reinke, at this time back in Würzburg, was my MD supervisor, and Felix was the person who really showed me in the lab the first steps by doing northern blot and all these techniques which we have done together 20 years ago. However, there are many other people in Germany which contributed to this work which I have demonstrated. And last but not least, there are many, many other people, international collaborators. I have to mention Wiebke Alt, Massimo and Fritz Kokside, and many others which are important who contributed. And the very last slide is that I believe that people are of key importance, and these people, these European people, have founded, as mentioned earlier in 2003, this ENSAT network. And I believe that ENSAT was one of the major drivers of progress in ACC. And in the future, I believe that we might go one step further and move ENSAT to INSAT, to an international network for the adrenal tumor studies. And with this idea in mind, I would like to thank you for your attention.